Today with Claudio we're going to analyze the treatment approach for subacromial impingement, which mainly involves the tendon of the supraspinatus and partly involves the infraspinatus as well. The problem is caused by a narrowing of the subacromial space, which does not allow proper sliding of the tendon within it, possibly creating adhesions or injury of the tendon itself as well. Treatment, therefore, should be aimed at an increase in the sliding of this tendon within it and a possible increase in the subacromial space. As we can see from the painting, it is divided into two parts. One part on the left side, which highlights the entire skeletal and articular component, and the right side, which allows us to better observe the myofascial component. To start with our treatment, we prefer a sitting position that allows us to have more control and enter the joint more easily, without stressing the patient's tissue too much. Especially this in case the impingement is more acute and painful for the patient. Techniques should be target joint compression so that parameters are concentrated within the joint and then using arm leverage to mobilize the muscle or tendon. Our treatment will start with a grip on the patient's upper limb, which we are going to wedge in here in our cubital fossa, blocking the upper limb with this hand grip. At this point, we're going to position ourselves on the patient's acromion, adjusting the table to the height that we need, apply a compression parameter, and create internal sliding due to parameters allowed by the shoulder. As you can see, we can work on a horizontal plane, also doing retropulsion. We add acromial compression, always respecting the pain and the patient's ability to move. And with the upper limb, we'll add parameters in the various ranges of motion. The range and quality of movement will depend how well the patient's shoulder can mobilize. We should start with very slow and deep movements so as not to stress the joint tissues. We can go in anterior and retropulsion. We can also add intra and extra rotation parameters. As well as abduction and adduction parameters. If the patient allows us to do so, we can also begin to insert some slight circumduction. At this point, we can switch grips. Ask the patient to grasp their side. We will always maintain acromial compression and mobilize the upper limb. We go on with our mobilization, a strong compression. At this point, we use the table, rest the patient's hand, ask them to move slightly further apart. Use the upper limb leverage again. We could also change the parameter of the upper limb to act on different joint sections. As we increase our movement parameters, we can change the positioning of the patient. We will continue now with the patient in the prone position. Let's continue our treatment in the prone position, then, which allows the patient to be more relaxed and allows us to get further inside the shoulder from the subacromial or even glenohumeral point of view. We're going to pick up the patient's arm, always respecting their pain and mobility. We can rest our hand on our leg and take advantage of the movement of the stool to apply our parameters. With the other hand, we will position ourselves within the subacromial sulcus and insert abduction and adduction parameters. We can also rest our hand on the table to ensure that we also have greater mobility in intra and extra rotation, being careful to keep within a bearable range of the patient. If the patient's shoulder allows us to do so, we can further increase our parameters by using the table. We're going to rest our hand on the armrest, insert our subacromial compression, and again mobilize. At this point, with a greater range of motion. The treatment of the joint part is integrated with a neuromuscular approach, which I will now show you on the other side of the patient. This position is greater because it allows the patient's shoulder to relax and allows me to get further inside the muscle bundles. We're going to start with the supraspinatus. What we need to look for is increased sliding of both muscle fibers and tendon within the sulcus. This position is excellent as it allows us to work on all the rotator cuff muscles. In fact, we can go on and treat the trigger points on the scapula, which involve the infraspinatus and the teres minor. I can do work, as in this case, of a static type, also, for example, on the posterior bundles of the deltoid. I can also opt for a more dynamic technique. We rest the patient's arms on our leg again. In this case, we can work in the subscapular area in the best possible way. The dynamic nature of the technique allows a smoother flow of muscle fibers below my hand, as I'm able to work both the trigger points again as well as the myofascial adhesions. At this point, our treatment can go on in the lateral decubitus position. So let's continue our treatment in the lateral decubitus position, a position that allows us to make wider movements, to take advantage of the hand support on the table, allowing us to focus on the joint. Again here, what we need is a good joint compression so that we can focus the movements on the inside while avoiding stressing the joint tissues. We can also grasp the patient's cubital fossa, load the weight on the head of the humerus in such a way as to generate, as you can see, a gliding motion within the joint. Let's hold this position. We can do a little more dynamic internal gliding work of the humeral head. Or keep our complexion inside, and by taking advantage of the patient's upper limb, create additional parameters. The parameters need to be focused on the inside and they need to have a small range of motion. as even a small improvement in internal sliding allows us 10 to 15 degrees in an active movement of the patient. An additional grip we can use, as we also seen before, is to wedge the patient's upper limb into our arm and to get back into the joint internally. This position is great because it allows us to work on the planes of motion of the shoulder. This concludes the treatment of subacromial impingement.